So my name is Dr. Abdalla Alzaabi. I am one of the TTL fellows with Julian and Amr under the supervision of Dr. Nemeth. So today I will be talking about blunt neck trauma. So I will begin with the case. This is an actual case we had last October of 2020. It's a trauma case. A 42 years old male who was involved in a motorbike accident. He tried to avoid the Aracon, and while falling, he fell forward and hit his lower face as well as the anterior neck. On arrival at the trauma bay, on your primary assessment, while you assess the airway, you see there's a fracture, lacerated mandible, lacerated tongue, and the C-collar in place. When you take off the C-collar, you see a red, swollen neck. The rest of your primary survey is unremarkable. His vitals are stable, starting 95% room air and GCS 15 out of 15, and his secondary survey is unremarkable. So I want you to think in your mind, how you're gonna approach and manage this patient, what injuries you are worried about, and what investigations, if any, you would like to do. I would go back to this case at the end of the talk. So, a blunt trauma to the neck account for about 5% of all neck traumas. It can happen due to direct impact from assault, falls, or sport injuries. It can happen due to deceleration injuries from MPCs, or secondary to strangulation, which can be caused by hanging or shocking. To predict what injuries the patient with the blunt neck trauma may have, you need to know about the neck triangles, both the anterior triangle as well as the posterior triangle, and all the structures found in these triangles, including the aerodigestive structures, the neurovascular structures, as well as other structures like the thyroid gland. For us in the emergency department, the things that we should worry about are injury, laryngotracheal injury, which can lead to airway compromise, blunt cerebrovascular injuries that if missed can lead to stroke, and the different type of spine fractures as well as spinal cord injuries. So my objective for this talk is to focus on these three injuries. So to start, laryngotracheal injury account for about, it's rare, it's only account for about 0.5% of all blunt neck trauma. The type of injuries that you might see are you might have injury to the vocal cord. You might end up with airway edema, hematoma, laceration of the airway, fractures of the cartilages and bones, as well as the most severe form, which is the complete separation of laryngotracheal tree. So how can you tell a patient with blunt neck trauma may have laryngotracheal injury? First, based on the mechanism, is there any direct trauma to the neck, the anterior neck? If there's any history of rapid deceleration, or if there's any history of strangulation. Then any symptoms patient that might present with that can predict there's a laryngotracheal injury. Example, is the patient complaining of any anterior neck pain? If there's any dyspnea, is the patient coughing up blood? Is there any change in voice? Is there any hoarseness, which is the most common presenting symptom for laryngotracheal injury? If there's any dysphagia or adenomyopathy. In your exam, when you examine the anterior neck, do you see any bruising or swelling in the anterior neck? Is there any signs of partial airway obstruction like stridor? When you feel for the larynx, is there any tenderness or crepitus that may indicate a fracture? Is there any subcutaneous emphysema? However, okay, the absence of symptoms and signs, still, if you still have high suspicion, you have to image the patient, and you cannot rule out laryngeal injury based on the absence of symptoms or signs. So what to do if the patient presents with anterior blunt naked trauma and you suspect their laryngeal injury? First, is the airway patent or not? If the airway patent, and you're going to assess for symptoms and signs of laryngeal injury, and also you're going to assess for the other injuries like neurovascular injuries. If you have a high concern, you're going to proceed with CTA of the neck. If CTA of the neck showed any injury to the laryngeotracheal tree, you have to consult ENT because these patients need a laryngoscopy for direct visualization, as the grading of the injury has to involve both the imaging, the CT scan, as well as direct visualization of the injury by laryngoscopy. So what to do if there's any signs of obstructed airway or systemic signs of laryngeotracheal injury? At this time, you have to be really worried because it's going to be one of the most difficult airway situation you can deal with. And if you rush to intubate the patient, you might make the situation worse, as you may turn a partial tear or injury into a complete separation of laryngeotracheal tree. So how are you going to proceed in this case? Besides applying the basic airway maneuvers and applying oxygen, if you still have time and the patient can be taken to the OR, do so. It's better to intubate the patient in the OR than the ER department because they have better equipment and you have all the services there. The anesthesia and the trauma services will be available in the OR. So and if you think you cannot intubate, the patient has to be intubated in the ER. So what you have to do? At first, you have to call for help. Involve anesthesia and the trauma surgeons as early as possible in the management of this patient. Have multiple airway plan. Have your double set up. You need to have two physicians at the patient head. One who had an experience with fiber optic intubation at the end of the bed, at the patient head, and the other prepping the neck for possible surgical airway. It has to be an awake fiber optic intubation. Awake, why? Awake means that you're going to intubate without paralytic agent. As given, paralytic in this situation may turn a partially obstructed airway into a complete obstruction. It also has to be a fiber optic intubation. Why? Because you want to see the airway while intubating the patient to avoid a laceration and to pass the tube past the injury. So this is a script and how to do a suggested script for awake intubation that you might consider. At first, if you have time, you try to minimize secretions and emesis by giving glycopyrrolate and Zofran. Make sure, okay, you apply local anesthesia to the airway using 4% lidocaine in the form of gel, spray, or nib. You are going to go through your 7 Bs. Make sure you very oxygenate the patient well. Apply a high flow nasal cannula throughout the procedure. Make sure to position the patient well and apply restraint, and make sure to sedate the patient with the ketamine and proceed with intubation. If fiber optic intubation is failed, the one prepping the neck has to try first cricothyrotomy and failed, which most likely is going to happen. He needs to know how to do tracheostomy in this case. This table shows you a classification and grading of the laryngeotracheal injury, which range from grade 1 to 5, from minor hematoma edema to complete laryngeotracheal separation. And the definite management of laryngeotracheal injury depends on this grading. For grade 1 and 2, these patients are managed conservatively. They will be admitted for 80 hours to 24 hours for observation in ICU setting to monitor for any airway compromise. They will need a serial of laryngoscopies to look at the airway to make sure there is no any progression of the edema, for example. For a grade 3 and 5, these patients usually will end up with tracheostomy, and they will need further surgical further surgical management in the future. So moving on to the next part is speaking about blunt cerebrovascular injury. Here, I mean injuries to the cervical carotid as well as the vertebral arteries. The incidence is higher than the laryngotracheotomy. The blunt cerebrovascular injury account for about 1% of all blunt neck traumas. Why you need to know about this and why you need to diagnose it? Because blunt cerebrovascular injury account for up to 20% of all stroke that present in patients less than 45 years old. So what type of injuries that can happen to the vessels in the neck? Basically, okay, so now you're going to have a minor intimal flap. You may end up with thrombus, dissection of the vessel, or pseudoaneurysm of the vessel. You might have a complete obstruction of the vessel caused by the dissection, caused by a large thrombus, or caused by the pseudoaneurysm compressing the vessel, or you may have a complete transaction of the vessel. So next, I'm gonna move and speak up. I'm gonna move and try to answer questions that I think are relevant to us in the emergency department, and I think you should know about the answer of this question regarding the blunt cerebrovascular injury. First, is there any screening criteria for blunt cerebrovascular injury? Yes, there are multiple. The one you need to know about is the modified Denver criteria. This one is based on the symptoms and signs that patient may present with, and the risk factors that may suggest there is a blunt cerebrovascular injury. When I think about the symptom and sign, I always think about the soft and hard signs of vascular injury. For the risk factors, it's based on the mechanism of injury and the traumatic injuries the patient may have. Fractures of the base of the skull is considered the most predictable risk factor for blunt cerebrovascular injury. And if you find any of these, any symptom or sign or any of this risk factor is an indication for CTA of the neck to rule out blunt cerebrovascular injury. So we will say now you had a patient, you suspect there is a blunt cerebrovascular injury, and you did a CTA of the neck and you found there is a blunt cerebrovascular injury. Do you need to manage this patient or not? Yes, you need to manage this patient. Why? Because if left untreated, up to 57% of patients with blunt cerebrovascular injury will end up with stroke. And if treated, this risk will drop down to between 4 to 0%. So now, okay, so what medical treatment you will treat the patient with? Will you give him antiplatelets or anticoagulant? The answer for this is still controversial. There is no specific guidelines for this, and many studies look at this and all suggested you should customize your treatment based on the patient and the type of injury patient has. So for example, you would like to give aspirin if there is contraindication to anticoagulants, or there is a minor injury like intimal flap. And you would like to give anticoagulant if there's a higher grade like dissection, or there is a free floating thrombus. So the next question you're going to ask yourself, for how long I would like to treat this patient? And do this patient need a follow-up and an imaging as a follow-up? Yes, every patient with blunt cerebrovascular injury need a follow-up imaging in 7 to 10 days. Why is this important? Because the follow-up imaging will help you to see if there's a resolution of the injury or there's a progress of the injury. If there's a complete resolution of the injury, you're gonna discontinue the treatment. However, if there's a persistent of the injury, you're gonna continue the treatment up to 3 to 6 months after the injury, which is the time taken to for the vessel to completely recannularize. So when our surgical options are indicated for cerebrovascular injury? So surgical options are reserved for high-grade dissection, like complete obstruction, transection, or pseudo-aneurysm formation. Also, for if there is a progressive disease or patient present with ischemic symptom despite maximum medical therapy. So if the patient is known to have a blunt cerebrovascular injury present with ischemic stroke, how would you manage this patient? Will you manage it at the same way you manage any stroke patient, or you will there's a different management for this? There is no different management. You're gonna manage same as other stroke patient. So basically, if they presented within time window, you're gonna treat with the TBA. If there's no contraindication for TBA. So moving to the last part of the talk. To talk about cervical spine fractures, both stable, unstable, and different types of spinal cord injuries is a big topic to cover in this talk. So I'll focus into two main take-home messages that I think they are really important to know regarding spinal cord injuries in general. First one, regarding the American Spinal Cord Classification, or what is known as the ASIA exam. You need to know this exam very well. You learn about how to examine for dermatomes and myotomes based on this. Forget what is written in Rosen, which is really confusing. So it's really important to know for your clinical practice, because this is the language you're gonna use to communicate with ortho spine, and also for your exams. You're gonna this question is common in a Royal College exam. So you need to know about how to test for dermatomes and myotomes based on this. The second take-home message is regarding neurogenic shock. First, take into account that any trauma patient who presents to trauma BA with hypotension, always assume it's hypovolemic shock secondary to hemorrhage. So always start treating with blood, with volume restoration, given blood. After the patients, after you rule out hypovolemic shock and you resuscitate the patient adequately, then you have to think about other types of shock. A neurogenic shock is a diagnosis of exclusion. So last type of shock you're going to think about is neurogenic shock. So talking about neurogenic shock and the difference between it and the spinal shock. For me, to make it easy, I think about neurogenic shock as an injury to the entire nervous system, whereas spinal shock is the injury to the spinal cord alone. So what happened in neurogenic shock? A neurogenic shock can happen in a patient with high level spinal injury, an injury above T6. So what happened here? When you have injury above T6, the sympathetic signals cannot travel down the spine. So you lose your sympathetic tone, and you have an opposed parasympathetic tone. So you're going to have autonomic dysregulation. You're going to lose your fight and flight response. So your body is unable to produce catecholamine. So there is no epinephrine or norepinephrine. So you're going to end up with bradycardia and hypotension. So how are you going to treat hypotension? Always treat with volume resus first. Then if you volume resuscitate the patient well, then you add pressors. For severe bradycardia, usually occasional treat with medication with atropine, and some patients may end up with pacemakers as well regarding the bradycardia. For spinal shock, spinal shock can happen at any level of the spine. So it's only injury to the spine itself. So what happened here? You're going to have a transit ischemia or hypoxia of the spine, which can last between hours to months. And you will know the spinal shock is ended and the patient had a permanent spinal cord injury when you have a return of something called a bulbocavernosus reflex. Basically, what is this reflex? That's when you tap or apply pressure to either the clitoris or the glans penis, you're going to have an anal contraction, which this will going to tell you the spinal shock is ended, and the patient have a permanent spinal injury. So back to our case. When we saw this patient, we thought we had time, so we decided to take the patient to the OR. I went with them to the OR. Basically, anesthesia at first attempted awake fibro-aortic intubation, and the surgical team were ready to do a surgical airway for this patient. So while we're applying local anesthesia, suddenly patient start complaining of difficulty breathing and has complete airway obstruction. Anesthesia were not able to intubate the patient. The surgical airway proceeded with the making the incision for cricothyroidotomy. However, they encountered a distorted anatomy. The patient had fracture of both the cricoid and the thyroid cartilages. So they decided to do an upper tracheostomy. They made the incision and they tried to pass the tracheostomy tube, but they were not able. At around that time, the saturation was going down 50. It was very stressful situation. ECMO was activated at that time. However, at the end, the patient was able to be intubated using a lower tracheostomy, as seen in here. This is the actual picture of the surgery. So in summary, always assume you are dealing with difficult airway in any patient with a blunt neck trauma that need an airway management. Always screen for blunt cerebral vascular injury in any patient with neck trauma or multi-system trauma, and know how to do the issue exam, and always treat a neurogenic shock with volume resuscitation first. I am done with my talk. If you have any questions.
Awesome, thanks Abdalla. There was one comment by, or there's two